Welcome to today's Methods Matters webinar, which is entitled, When a Pandemic Gives You Lemons, You Run With It, Personal Health Record Implementation Obstacles and Opportunities. And it will be presented by Lindsay Burton and Mindy Smith and moderated by Leanne Curry. My name is Belinda Jampo and I am your host today. And our Methods Matters webinar series is a monthly webinar series from the BC Support Unit's Methods Clusters, and it showcases emerging research and patient-oriented research methods. I would like to acknowledge the ancestral, traditional, and unceded territories of the Squamish, Tsleil-Waututh, and Musqueam nations from whose traditional lands the BC Support Unit operates in. So here, I just want to let you guys know that we do encourage an attitude of continuous learning. So this means approaching new ideas and diverse perspectives with openness, respect, and curiosity. So the aim today, and for all of our work, is to center previously underprivileged voices. So with that in mind, I'm going to stop sharing my screen and pass this all over to our moderator.
Thank you so much, Belinda. And I'm incredibly pleased to warmly welcome our presenters today. Lindsay Burton, first, is a research coordinator in the School of Nursing at UBC Okanagan. And for the past 5 years, she has worked in the research area of utilizing technology to address issues in access to health services in rural communities. Our second presenter is Dr. Mindy Smith, who is a teacher, mother, activist, retired family physician, cancer survivor, and disabled person who brings her interest and experience, and I'm going to add passion in patient and family perspectives to her patient engagement work. I'll pass the baton now to Lindsay, who will share her screen, and I really look forward to hearing your presentation, Lindsay and Mindy.
Thank you, everyone, for joining us. I'm here with Mindy to talk about this personal health record implementation project that we've been working on for the past few years. Along with team members, Dr. Kathy Rush, the principal investigator, Dr. Selena Davis, and our regional liaison, Mona Mate, with additional team members, including Dr. Leanne Curry, Matthias, and another patient partner, Heidi Scott. So to get right into things, we've had a multi-phase study. So we're going to go over kind of what the problem is, what personal health records are, some pivots we had to do in response to the COVID-19 pandemic, and then the lessons that we learned in next steps and really pushing forward this work and particularly maintaining it, the patient-centric research and practice perspectives. So what are personal health records? Personal health records, essentially the idea is that it's an electronic hub for patients who would ideally be the owners to input health data that they can share with health providers and health providers can share with them in order for it to be a place for everything to be in one spot where they can share information, it's confidential and it's secure. And this image that I have on the screen is the ideal situation. We're not quite there yet, but we're working on it. So cloud-based, internet-based personal health records, being able to share, access, manage, contribute, and control from the patients. And at the moment, there's a bunch of different variations about what that might look like, whether it be a standalone system that you input in information in manually, something that's interconnected where you can have stuff coming from different places, or a tethered system where information can be put in automatically from multiple sources. So the idea behind personal health records is that they should be and can be and are beneficial to patients in that it can increase engagement from patients in their healthcare decision-making, increasing their engagement in control and ownership over their health decisions. And there's been studies that show that it can reduce emergency room visits and preventable hospital stays in patients with chronic diseases. So that was one of the interests in this research project, was really looking at patients with chronic diseases and using a personal health record to improve health outcomes and engagement. However, some of the limitations that are faced is that uptake at the moment is poor, limited functionalities of personal health records, having poor uptake in healthcare practices and clinics, a lot due to the integration with existing health systems that clinicians and practices use, and then stakeholder involvement in order to overcome some of these barriers. So that is the kind of overview of what personal health records are and the background about what we were going to be talking about. And I'm going to pass things over to Mindy to go over one of the first phases of the study as we've been exploring this area.
So in order to begin this project, we wanted to get an idea about what the priorities and perspectives are for personal health records from patients. So we started our phase 1, and that was to understand rural patients and providers' perspectives before implementing. We rural in our areas, there are fewer providers, there's limited high-speed internet. For example, I'm giving this presentation from my car so I can be in a hotspot. Really want to see if there are ways that people can use these digital solutions to improve their care. So we began recruiting patients from a patient advisory committee, that I chair, and primary care providers in our rural region, and they participated in separate focus groups that were facilitated by a research team member. We analyzed the data qualitatively using main themes with a consensus process that was supported by NVivo data management software. And our results are what I'm going to be presenting next. We found 2 central themes. First, the patient-centered focus was important to both patients and providers, yet with differing orientations to the types of patient-reported data that were valued and the PHR control. In addition, both groups were very excited about the opportunities to do information sharing with this media, yet needing to establish and communicate boundaries. So with respect to the patient-centered focus, there were similar views with patients and providers on being able to house a comprehensive patient history. So we've included some quotes from the patients and providers about this topic. One of the things that patients reported that I found particularly interesting was the frustration on having to repeat your story, your healthcare journey over and over to different providers, and that having a personal health record would obviate that need. However, there were differing views of the types of patient-generated data that were desired. Patients talked more about health promotion data. So things like diet and activity logs, being able to track screening events, those kinds of things, whereas providers were really focused on clinical information. So blood pressures or disease-specific questionnaires like the PHQ-9, which is used to screen for depression. There were differences in agency and control. Patients uniformly felt that the patient should be the controller of their personal health record and be able to make changes to that record, that these were their own data that they owned. Providers, on the other hand, had a range of opinions about personal health records. And while all acknowledged that patients should have access to their data, there were a range of sharing options, from reading only to being able to actually input data and share to owning their personal health records. There were also differing views on the patient impact. So the one patient mentioned that she felt that past negative relationships with providers might not allow a fresh perspective of the patient within their PHR, but providers were primarily concerned with data sharing being anxiety provoking for patients. And we'll talk about that a little bit later in our lessons learned, because there are data to support both sides of those concerns. With respect to communication, there were very similar views that flexible communication was a great benefit of personal health records. So patients talked about being able to email back and forth and the value of that. Providers also felt like they would be able to reach out to patients in between visits and that this could be a real benefit in caring for their population. However, there were different views with respects to boundaries and limit setting. Not surprisingly, patients feeling that they should own their personal health record, they also wanted to be able to set limits in terms of who would get access to which types of data. Providers more often were talking about boundary setting in terms of too much information coming into their offices, which would create workflow disruption and added time for themselves and their team members. So I'm going to turn this back over to Lindsay to talk about the next phase of the study.
Thank you, Mindy. So after we held all these focus groups and we got this information on perspectives of personal health records, we implemented a personal health record in 4 clinics in the rural communities of Kootenay Boundary Region. We chose Input Health as our personal health record. And the idea behind this was to gain insights of the experience of patients and providers in terms of the value, the use of patient-generated data using a personal health record that was integrated with provider electronic medical records and in rural primary care networks. Primary care networks being, in these clinics, allied healthcare workers, including nurses and social workers and other healthcare workers working with the physicians as part of these care networks for patients in these rural communities. So this was our implementation timeline. So we alluded to, even at the very beginning, this idea of being integrated with clinic electronic medical records. Unfortunately, at the time that we launched our study, we did not have interoperability between the personal health record that we chose and clinic electronic medical records. However, we forged ahead. We recruited 4 clinics to be a part of this. We started training in January of 2020. We began patient recruitment in the end of January, February 2020, and then by March, we had hit the height of the COVID-19 pandemic, and that had very big impacts on our recruitment and the scope of our study and what we were able to do. So what we did then was we adapted. We changed a little bit of the scope, and I'll talk a little bit more about what we did for that, because we had originally been looking specifically at the patients with chronic diseases. And because the COVID-19 pandemic kind of threw us a curveball, we decided to open up the personal health record use to all clinic patients instead of limiting our practitioners. You can only use this PHR with a certain population of clients. We felt that there was benefits. Our clinicians felt that there was benefits. So we decided that we would change our scope and open it up to all clinic patients. And then we wrapped up in the fall of 2020. So the framework that we used was the REAIM framework, Reach, Effectiveness, Adoption, Implementation, and Maintenance, which is an implementation science framework for examining the success of an implementation of a new project. So I'm going to go over what we learned under each of these headings as we implemented this personal health record. So we had our target population that we refer to here. These are the patients that we originally were looking at who had 1 or more chronic diseases. And then we have our all participants. And this is when we opened it up to use this personal health record with any patients in your clinic because we feel it could be beneficial for you. So we had 21 patients that we originally targeted, and then 148 participants ended up using the personal health record over the course of the study. And we had the majority of these patients came from 1 clinic, and I will talk about that a little bit. So the patient perspective of the effectiveness. So We measured effectiveness in a few different ways. We had a pre and post survey that we used for our target population, these 21 patients. So when we recruited them into the study, they filled out quality of life, self-efficacy, and patient engagement or patient activation scores. And then we measured it again after 6 months of them using the personal health record. So by the end of the implementation, we only had 12 patients who still filled out the survey. Essentially, our population had a high comfort using computers. Not very many of them had heard of or used personal health records in the past, but they did expect to use it going into the study. We didn't see any significant changes in any of our measures over the course of the study, but patient activation and satisfaction with providers were generally high, even if they weren't changed. And satisfaction with the personal health record was overall neutral. We did run into issues when we measured the use of it, where use was fairly low. And I'll talk about that a little bit as well. As far as the provider perspective of the effectiveness of these personal health records, I've highlighted here in red the key barrier that every single clinic practitioner cited was that the personal health record was not integrated into their electronic medical record. And that was a huge barrier for use for these practitioners, particularly because in the face of the pandemic, they were already strained. So what they ended up having to do is, if they wanted to use the personal health record, they would have to create a new profile for each of their patients in order to get them set up in the system. So they would have to have 2 screens open at the same time. If they wanted to use the personal health record to send a questionnaire or get some data from the patients, they would have to set them up completely new in a dual system. And then if they wanted to then take that information that they got from the personal health record, they'd have to manually put it over into their electronic medical record. And that created a lot of extra work. However, Clinic 3, you'll see, which was the one where the majority of our patients came from, they used it a lot. As part of our adaptation, and I'll show you in a slide a little bit later as well, we set up a custom questionnaire for them so that patients could submit photos, and they found that very, very useful for them. And the provider who used it the most used it almost every day because of that. So again, the interoperability of the systems, it prevented adoption from our providers. With the COVID-19 pandemic, even though they were switched to virtual care, they were also given additional tools because of the pandemic. The personal health record that we chose had video conference and appointment capabilities, and most of the clinics that we worked with switched to Zoom instead of using that feature within the personal health record, again, because of that lack of integration. So this implementation. So this is a chart of all of the patients and when they were added over the course of our study period. So you can see we were doing training in January and recruitment January, February, and then in March, just as things were starting to pick up, the COVID-19 pandemic hit us and our recruitment levels dropped in all but one of our clinics. And so this clinic with the great big spike here, that is our Clinic 3. We did this customization where they could submit photos for their patients, and they used it almost every day. And we're very pleased with it and found great value in using it. And then by October, the champion that we had at that clinic left for a new job, and the rest of our clinic practitioners at that time had stopped using it because of cited issues with interoperability, and they had found workarounds in other ways. So we have decided to take these lessons as, you know, when you find a niche use for it, the satisfaction was high, the use was high, and we just ran into issues that we knew would be a problem at the beginning, that interoperability. So in addition to this work that we were doing with the implementation, when the pandemic hit and a lot of our work stopped or had to shift, we decided to take what we had learned in our phase 1 focus groups, this idea about electronic data sharing, the emphasis from the patients on health promotion and the emphasis from the practitioners on more clinical data and explore that a little bit deeper in the use of virtual care in some clinics. So we did a couple of side projects. One of them was a micro practice case study where this micro practice in one of our rural communities, they were using virtual care completely in their practice for years prior to the pandemic. So they had it fully integrated in their system. They do online booking, they do virtual appointments, they do texting, calling, emailing, they've got email broadcasting to their practice. And so we did focus groups with this practice, and we looked really closely at the lessons that they'd learned, tools and characteristics of them that we could share with other practices, because the satisfaction with their patients and them was very high. We had focus groups with their patients, with their patient groups as well, to see, what their experience of doing this fully integrated virtual care model was like. And some of the highlights that we found in this practice were this communication approach, where both practitioners and patients were able to initiate conversation, whether it be asynchronous or synchronous. They created clear boundaries on response and expectations. If patients were sending healthcare data at 2 a.m. on a weekend, there was no expectations that the providers would look at them at that time. And also that they had this patient portal and secure email, as well as the mixing of virtual and in-person care. Having this integration of virtual care into their model and these different ways of doing electronic data sharing didn't mean that they never saw their patients in person. Their patients felt safe and empowered, and to ask and be able to share when they felt it was important for them to be seen in person. And then another thing that the team sent with us was this journey to get them. And it took them 5 years to get to where they were with their integration, setting personal boundaries, doing a lot of education, not only for their patients, but for themselves as a practice team. And they were able to share with us some really important lessons on the fact that it's possible, it's safe, it's effective, it's secure, and the satisfaction is high, particularly with the patients. So some other exploration we did was this idea about, okay, what are some of these provider perspectives of electronic data sharing? We've seen kind of this case study and we know how patients feel about it. And what we did was we did focus groups with additional providers in these rural communities, not just the ones that we did the personal health record implementation with, and looked at how they were using virtual care and electronic data sharing methods and what their perspective was. And we've split it into, this full use. They are fully integrated with electronic data sharing, some partial, they use it here and there, but it's not integrated as a daily part of their practice. And then practitioners as well who used it very seldomly, the occasional email, or just using phone calls as a way of getting patient data. And what we found was a lot of the perspectives and barriers that these providers were sharing with us about the issues of electronic data sharing were very similar to what we saw in our phase 1 conversations with these providers, where they're concerned about boundaries, they're concerned about responsibility, and the patient capacity. And one of the very interesting things that we found in one of the practices who didn't use electronic data sharing very often was not about the desire to use it or fear about patient abuse, but it was the fact that the technology that they had in their practice wouldn't support it. And they didn't have a strong enough internet connection. They didn't have quality video capabilities for them to provide these services. But overall, the lessons that we learned was education and capacity and passion for it really goes a long way. And the integration, our partial use people, one of the barriers they cited was, even though they're using it a little bit, it's hard for them to fully embrace it because it's not fully integrated, where they would probably use it more if it was a one-stop, like this practitioner said, an all or nothing thing. Okay. And so that is sort of our big overview. I'm going to pass things back over to Mindy to talk about taking these lessons that we learned forward.
Thanks. I'm going to keep my camera off because I understand my voice goes in and out, and hopefully that will help. So one of the things that we certainly believed in coming into this project was the importance of doing patient-centric research. So having a patient partner, myself on the team, personally, it was a fabulous experience of being part of this team. But I think one of the roles that I played was trying to continue to focus on how the patients are viewing these kinds of changes and what their needs are. So in terms of key learnings about technology, from both the patient provider perspective, so next slide, there needs to be an integrated system. So when the PHR lacked integration, the clinic just wasn't using it. And then patients tended to fall off as well because they felt like there was really no point in using it. In terms of what we learned pre-implementation, we weren't really able to make a lot of the changes in our implementation based on what we learned in phase 1. So that was a problem in not being able to really look at data sharing, who controls, and the perspective of what kinds of data were being generated by patients and what were being valued by the physicians. And of course, COVID-19 really influenced our ability to enroll. However, for the one practice that had not had the capabilities before of sharing things like photographs, there was huge uptake. So where there's a need, there was certainly a lot of excitement around this technology. So in prioritizing patient-centered approaches in practice, we've certainly found, not surprisingly, that patients want better access and access to their health information as well as their providers using virtual care. Providers, however, feel overwhelmed primarily with COVID-19 shifts and unsure of virtual care, some because the capabilities within their offices are not good. And they also really haven't yet been using patient-generated data in a meaningful way in terms of practice improvement. So all of those things need work. In terms of research, moving patients in the engagement spectrum, I think, is important. I really felt like I was engaged as pretty much helping to give input and even sometimes co-designing our techniques. But I find that most patients in research are still simply providing input and not really moving in the level of engagement to the co-design or actually bringing their own needs and concerns into the research as major topics for discovery. Going forward, we really need to look at system level changes. And the kinds of things we think need to happen on a system level, and this is interior health authority level, there needs to be stable funding and low-cost digital tools available to practices so that they can begin incorporating more of them. We need to be doing work on team workflows. The team-based care in our area is still fairly new. And so the development of optimal team workflows and responsibilities needs to be developed. It would be helpful to learn about best practices like this microclinic as practices begin to go forward and figuring out how to integrate these things without overwhelming their systems. Infrastructure is huge. High-speed internet is not available in a lot of rural areas. And so there's a lot more work that needs to be done, not just in patient homes, but in practices. Training is needed for both physicians and patients who are early in their experience of using these various digital tools, but once established, they can be hugely beneficial, as we've seen in the microclinic practice. And finally, this is really an important way to allow patients to have better access. And we need to be looking at ways to make that access less worrisome for practitioners, perhaps by doing things like providing lay patient health information. So providers are worried about patients being able to understand information that they see in the records. But if, for example, on an imaging test, there was a lay abstract, if you will, that said, here's what the test shows, this is concerning or not concerning, and here's what you should do about it, that would take a lot of the worry out of it. And I think that studies certainly have shown that patients are far less anxious than providers are worried about.
Okay, thank you. And I will stop sharing my screen and turn things back over to you, Leanne.
Excellent. Thank you very much, Lindsay and Mindy, and for such a great presentation, especially I think the pivoting challenges, I think were really, really challenging during the COVID time period. But you did make some lemonade out of those lemons. So there is one question from the Q&A, and then I'll have some other questions for you. I just wanted, before I ask that question, can you clarify the microclinic that you referred to in the one of the pivot studies? Was that clinic involved in the first round of your main study when that you were recruiting? And so how did you identify that clinic, that microclinic, as being the case that you were going to examine?
Absolutely. So in our first round of like our initial testing the personal health record and the PHR implementation, we chose clinics that were part of the primary care network in the area that we'd identified. So we approached all of the primary care network clinics and to recruit them as part of this personal health record implementation. After we had done that and we're looking to shift and explore further perspectives on electronic data sharing, what we decided to do as a team was identify other clinics that aren't part of the primary care networks, but are still using digital tools in part or in fully in practice as a way to get perspectives on electronic data sharing from people who are actually using it, as opposed to the clinics that we had approached before who didn't have a lot of these tools. So our regional liaison, Mona Mate, who is fabulous and very instrumental in getting a lot of these clinics on board, because she knows a lot of them and works in practice with a lot of them in implementing and training for some of these digital tools, approached a lot of these clinics that she knew used these and recruited them in for us to talk with. And it was, we got a perspective that we wouldn't have previously because the clinics that we recruited for the personal health record hadn't been using it for 5 years, like this micro practice.
Excellent. Thank you so much. I'll have a follow-up question on that in a moment, if there's some other, but first I'm going to ask you the first question. Are there any implications for learning health systems as they plan to integrate health records?
I think that there are a lot, and I think that there are more teams than just us that are working on this. There's the Rural Coordination Center, BC, that's working really hard on integrating and working on this. And I believe, and Leanne, you would probably even know this more than I would about the data exchange that they're working on pushing forward to prevent a lot of these interoperability issues. So, you know, that's kind of the main one. And I feel like we've known it for a while, and this implementation, you know, showed that, you know, while the interoperability integration isn't critical, if you have a need and that need is great enough, you will use it. Like our one clinic did, they found these pictures instrumental to their practice in the way that they were treating their patients. So they used the workaround, but this interoperability is key for patients and providers. You don't want to have to duplicate your work, particularly, you know, in busy, stressful situations. And Mindy, I think, can expand on that as well.
Mindy, please.
Thank you. I just wanted to add that I think it's really important to bring in your staff and patients as you're looking at these different systems to see who can be your champion as you move forward in integrating these digital systems, and also to find out better about your patient needs. A lot of the practices don't have any emails for their patients. So I think you know, bringing in patients and staff early in this process can be very helpful.
Yeah, and we, as Mindy highlighted as well in kind of our final slide, the education and training. As we were discussing in these focus groups with these providers who used some digital tools, but not a lot, they talked a lot about how, you know, they're able to make these changes and able to implement these digital tools because they're a small team and they can make changes quickly without having, quote, 10 meetings about it. But also they talked about how they aren't using these tools to their fullest capability because they don't know the full capability of these tools. And I think that was a big part of it as well, where they're using maybe 10% of what they have access to. So that the training, the purposeful use of it as well, that was a big thing that came out of this micro practice, is they were very intentional in what they chose. And that's what made it work for them.
Excellent. Thank you very much. The next question is about your research team. The question is, do you have any advice for research teams who might be faced with future crises? So what helps your team stay resilient?
Well, we were blessed with a very, very good team to begin with, I think, which helped. And Mindy, I don't know if you want to answer this as well. I think that you were a big part of keeping us resilient and motivated.
Sure. What I found was that regular meetings were really vital. So we met every week, and that was a huge benefit. So when problems came up, we were ready to talk about them. You know, Lindsay being able to devote so much of her time to the project was key. But I think being able to talk with each other and trust each other made us able to be really creative when problems occurred, so that we could think about how we could use the time that we had while we were struggling with enrollment to look at things like how communication is being handled in the media around COVID-19 and instructions to patients. And so it really was, I think, a matter of these regular meetings and brainstorming all the way along.
Yeah, and having team dynamics where every single team member, regardless of their role, has valuable input for which directions we should go in. It doesn't just have to come from our core, like researcher team, our patient partners, our community members all have valuable contributions of what direction we should go. And I think that really helped us.
Excellent, thank you. And I think that it's kind of testament to the focus of your research being on patient-centric ideas and actions. And your research team was doing that as well with a patient partner, and you're also with your community members who sounds like we're integral part of the team.
Yeah, and I think as well, it's we were also living through the pandemic, so we were able to put our patient hats on as well as part of this.
Thank you. The next question is coming from a systems perspective. Do you think that the conflict between patient data access and patient data sovereignty sometimes clouds this moving forward. So the fear of arguments over who owns patient data, does it get in the way of developing personal health records? I hope I represented that question well enough.
I think that's a big question again, Leanne. You might even be more qualified to answer that than I am. But I think Mindy, I believe we had lots of conversations in this as we talked as well. You know, this issue over ownership, there's not a lot of evidence to support that fear. So I think it is clouding it, but there's a lot of other complicated pieces that are going on that are also clouding. And I think, how long have we been working on this, Leanne? Personal health records in BC?
For, yes, a long time. And so
Yeah,
it looks like Mindy wanted to chime in.
yeah. Thank you. I do think that some of it is that helps is using it. So as you begin to use it with your patients, you find that you are able to do things like set boundaries in terms of when asynchronous communications will be addressed. I think all of the practitioners acknowledge that patients own their data, that that you should have access. And I think that once they begin using these systems, particularly with training and support, it gets a lot less scary. So in the practices who are actually using it, there was a lot of enthusiasm and not so much worry. But I also think on the health authority side, we need to do a better job of communicating what those data mean so that people, when they're accessing their information, aren't overly concerned and have the ability to say, okay, if my sodium is 1 point out of range, what does that mean? And do I need to worry about it? And, you know, at the bottom, just having a little single line that says, don't worry, this is fine, would be very useful.
Yeah, I think we're also still very oriented around the idea that these personal health records are attached to, tethered, and essentially controlled by these clinics, where we're taking the perspective of it needs to be interoperable with the EMR, and in practice, as we talk to these clinicians who are using it, it's still something that they own, that they pay for, that they essentially control. So whether or not that's the ideal of what a personal health record is, if it's attached to an EMR, does the patient necessarily have the same kind of control or ownership as if it were separate? I don't know. And in a lot of the issues that, well, not issues, but a lot of the things that we saw with the personal health record that we implemented was all of the communication had to be initiated from the provider. So the patient want, need, or interest in it still relied on the provider being the first to initiate. So, you know, even though our providers agreed that patients own their data and patients should control, the way that the systems are currently set up and we've been testing are still essentially gatekept by these providers.
Thank you. And I think that's a big crux of the issue. And a little digression, there was a publication recently about a lot of incoming family practitioners don't like the fee-for-service model. It was a CMAJ publication. And I think that the overhead that's involved in setting up these digital tools can feel daunting, especially to new practitioners who are launching their practices. There's another question so Matthias has a question. Do you want to speak to the one thing, either a lesson or a fact or an idea that you know now that you wish you had known in 2020 when planning the project?
Thanks, Matthias. I joke because Matthias was on our team. I think in May 2020, I don't know about May 2020, if there would have been much that could have changed, but I do think it's the provider engagement and capacity was a big thing, particularly for our implementation. Our third clinic that had massive uptake essentially was because the clinic practitioner there dedicated one of her team members to this project, and they found value in it. They used it, they championed it, and we checked in with them. I checked in with them regularly, and if they needed changes, we were able to facilitate that for them. And then when they left, it also left. I think being able to alleviate those fears, yeah, and being able to support. I'll turn it over to you, Mindy, too, as well. But I think, in the crux of this COVID-19 pandemic, one of the things that we were really happy about for the clinics that we had engaged and trained already on this personal health record is we had provided them a tool that they needed and were able to use at a time where we were sort of scrambling and in great change. And one of the things I'm quite happy about is the fact that we were able to take this research project that we were looking to do for patient engagement and give it to these practitioners to open up and use it in a meaningful and important way for their patients. And even though that didn't happen in all of their practices, the fact that one practice was able to find extreme benefit and use it every day and want to continue using it after, that ability to change and adapt is great. Mindy, I think.
Mindy.
Thanks. Yeah, I would just add that I think one of the things that might have been good to implement early on is support for the clinicians, to identify that practice champion, but also to have regular meetings so that they could support each other as they were making these changes. So I think knowing how difficult it was, particularly when we couldn't offer them an integrated system, it would have been nice to have the practitioners have regular meetings, that lead person from their office to try to work through some of the concerns and talk about them and see how the practice that was able to adapt it so well would be my lesson that would have been nice to have implemented early on.
Yeah, I think there's some evidence in the acute care setting where that level of support is required for at least the first 6 months, sometimes up to 18 months, until people have figured out how to fit it into their mental model of how their workflows work. There are no more questions from our audience, but I do have one more question that's kind of linked to this. And when you were talking about the micro-practice study, Lindsay, and then you talked about the champion that was at that one clinic, were there any key characteristics of those folks that you might be able to kind of anecdotally describe that made you see something slightly different than the others? This is putting the yeah, so you've mentioned a couple of things already. For example, like the Clinic 3 had allocated the use of the technology to one person. Are there any other anecdotes that you or Mindy have in regards to those characteristics of, I'm going to call them the early adopters?
I guess I can, for the micro clinic practitioners, I think that they were a really beautiful and unique case. And I think we were all blown away by their practice, and we walked out of that focus group wanting them to be our doctors, because they were so passionate, and it was just a clinic manager partner and a GP. And what they were willing to do was try something and give it up and try something better if it didn't work, instead of forcing something to fix or working along. They, as part of their 5-year journey, they made changes, they tried stuff that didn't work and did new stuff. And I think that their original idea was they would do all these tools because it would reduce their overhead and would end up being easier and cheaper for them in the long run. And I don't know if that was necessarily the case for them, but it ended up working in the long run. And I think that their resiliency as a team and their willingness to change and fail and educate themselves and their patients is what paid off in the long run, and their autonomy to do so. So I think that, these practices that are within the health authority don't have the same autonomy as these privately run clinics who can make these changes without the same level. They got to pick exactly what tool that they wanted, and if it didn't work, they were able to scrap it. So they have the advantage over a lot of clinics that don't necessarily have that. But then again, the clinic that adapted, that had a team member assigned to it, that was a health authority run clinic. And the advantage there was that, this is in their scope of practice. They felt that this was important and they were able to adjust it, and they weren't hampered by that fee for service schedule. And, we heard practitioners cite over and over again, like, this is good. And we love this, especially because of COVID, we're getting paid for it. Will I still do this if I'm getting paid? No, maybe not. So particularly the micro practice, their resiliency, their passion, and they were very, very patient-centered. Every time that we asked them a question about, the value of patient data and how they use it and do they trust their patients, they were confused by why we were even asking that, because absolutely they trusted their patients, and absolutely there was value, and absolutely their patients were an integral partner in their care.
Great, thank you. Mindy, do you have any comments about those characteristics? Anything to add?
No, thanks.
Great. So I think a few things you said, some sort of passion, willingness to try something and then abandon it if it didn't work out for them, and patient-centeredness, including learning how to use the technologies themselves to be able to be patient-centered, as well as putting the time in to teach the patients how to use the technologies in a way that worked in that context. Sound like some key characteristics that are important to note. Great. There aren't any other questions, and I don't have any other questions, but I'd like to just ask you, is there any last word you'd like to say, Lindsay or Mindy? And Lindsay, if you can go first.
No, I think that Mindy and I have covered everything that I thought of. I mean, this whole experience, even though we were forced to make a lot of pivots because of the COVID-19 pandemic, all of the projects that we ended up branching into were, if anything, highlighted the importance of this and definitely expanded our knowledge in different ways and pushed us to, and Mindy in particular pushed us to have much more of that patient-centered focus, because it was easy during that kind of chaos to not have that emphasized. So really, really grateful that she was able to keep every single meeting being like, well, the patients. And I think that was a big thing for us.
Great. And any last thoughts, Mindy?
No, just that it was a pleasure to be part of the team, and I learned a lot, and the team was very responsive to the things that I felt were important. So
great. Okay, thank you. So we'll close the webinar today, and I think Belinda's going to come back and close us out.
So thank you to our presenters for presenting. That was really insightful. Just one last slide for you guys at the end there. We do have a hashtag today, so if you want to connect and have a discussion about today's webinar, please use our hashtag Methods Matters via Twitter to share your thoughts and opinions on this. And if you would like more information about this specific research topic and just the Methods Clusters projects in general, you can go to methodsclusters.ca. And for more information about this project, you can visit, we do have a tab, I believe, under the Methods Clusters page under Understanding the Meaning and Value of Patient self-reported data using personal health records within primary care network in rural BC. So under that, you can find more information about the specific project. Thank you for taking the time to join us. Yeah, so that's pretty much it. Thank you all, and we'll see you next time.
Thanks, everybody.